So I am excited to have this session. There's been a lot of conversations going on over the last 2-3 years in the area of mobile integrated health. It's something that is really becoming a very critical and hot topic because of its ability to increase access to care. And this is just a really great way to do it. Has the potential to be a really great way to do it as soon as there's certain things that get worked on. The other reason the timing is so great is because we just learned yesterday that Governor Kelly has issued or will be issuing a proclamation in October announcing Mobile Integrated Health Week. And you're going to hear that Missouri has a pretty strong mobile integrated health program. And Doris shared, she's like, I don't even think we have that yet. So kudos to Kansas. The other thing that's been happening, just so you're aware, is the state Medicaid office has been having conversations with various stakeholders about mobile integrated health and collecting information so there can be that continued look at how can this be something that is sustainable and who are the partners that need to be part of this conversation. So there's a lot going on around this area. We also have health centers in Kansas who are already doing this work, and we're going to hear from one of them today. Kansas has also been the recipient of a Patterson Family Foundation grant, and there are 3 counties in Kansas who are working on this effort, and a lot of that work is being led by EMS. But in one of our counties, we have a health center that is working with some of their local community partners. So I'm going to do an introduction of our 3 speakers, and then we're just going to start this conversation. So first we have Wyatt Beckman, and Wyatt is the Senior Analyst and Portfolio Strategist with the Kansas Health Institute and has been instrumental in facilitating these conversations on this topic. He has a leading role in KHI's activities and projects focused on rural communities, and today he will share about the current status of M.P.H discussion that's taking place in Kansas. And then we are very grateful to have Doris join us. We had another speaker who is going to join us, Justin Duncan, who's been very instrumental in this work, particularly in Missouri, but also at the national level. He was unable to do so, so Doris has joined us today, and we appreciate that. She is with Community Asset Builders, a nonprofit consulting firm focused on empowering communities through strategic planning, resource development, and program implementation. And her emphasis is mostly on federally qualified health centers, local health departments, state departments, and other statewide organizations. And I'm sure she'll share a little bit more about herself as well. And then lastly, not worstly, bestly, we have Amy Falk. And Amy is with the Health Partnership Clinic right up here in Johnson County. And Amy's going to kick us off here first with just a quick introduction about her organization and the community she serves.
Sure, so thank you. So as Alice said, I'm Amy Falk. I'm the CEO of Health Partnership Clinic, and we are an FQHC here in Johnson County. Our main site is in Olathe, Kansas, which is, and I'm directionally challenged, so I have to think about this, but about 10 minutes to the west of here on a good day. That is our main site. In addition, we have a pediatric practice on the campus of the old Shawnee Mission Health Center, or what's now Advent Health. We have a school-based clinic at Shawnee Mission West High School, and then we also provide services at Safe Home. In addition to that, we have clinics in Franklin County, Ottawa, and then Miami County, which is in Paola. Our services, like everyone else's, medical, dental. We've just started behavioral or prenatal about 18 months ago. We also have substance use disorder, and that program is growing, having added also DUI assessments, and we will be adding gambling addiction treatment in, I believe, later October.
Well, thank you for all you do and all your staff does to support the community as well. So again, each of these folks are going to share some remarks with us, and then we're going to do some interactive questions with everybody. And then we really want this to be an opportunity to ask questions, to gain information, so that we can help inform that conversation that's taking place at the state level as we look towards seeing how mobile integrated health might be a great resource for Kansas. So would you pass this to Wyatt, please?
Thank you. Well, thanks for being here, everyone. Am I still on? Back to the room, looking back here. Am I good? All right. Can you all hear me? Yes. Great. Okay. Well, thanks for being here. Fun side note, you get 2 Beckmans on this panel, even though our names are slightly different spelling. That hopefully is a real treat. Doesn't happen very often. We're actually going to do the questions right now. We want to just get a real quick sense of where you all are at when it comes to M.P.H. And that QR code may be a little small, so I'm going to make it a little bigger here. So before this session started, answer this as if, we know you walked into the session knowing it was about M.P.H, but before today, how many have heard of M.P.H? Hopefully people can, and don't be shy. If you need to stand up and get a little closer, please do that.
The answers are coming.
Yeah, awesome. So we do have most people, but not everyone. Okay. I'll just give it a little bit longer here. Staying pretty steady at about 20% that haven't heard about it. Well, I hope that after today, that number, you feel a very confident yes after this. I'm going to move us to the next one. So you should be able to just go to the next question. So now we want to know who's discussing things with partners. Have you had conversations about M.P.H? And we're about 50-50. That's really helpful to know. Mm-hmm. And again, after today's session, I hope you feel more equipped to go have those conversations. This one's a little different. It's open-ended. So those that said yes to the previous question, you are having conversations. What are you saying? Who are you having them with? Is it certain organization, certain departments, certain state offices? Someone's just sharing what it is and what the need is. Thanks for first response. With some other nonprofits. Okay. Local EMT. That person's been really busy. EMS, state associations, rural hospitals, and clinics. None, nobody. Okay. And you can keep answering even as I move forward. This is helpful for us to know. Mm-hmm. Schools and nonprofits. Awesome. Okay, our last question here, and this is sort of going the furthest. How many are actively working on an M.P.H program? Okay, we're about 20 to 30%. A little higher. Okay, awesome. Well, thank you all so much for participating in our little poll and giving us a sense. For those that are especially in that 20% that said this is pretty new to me, I'm going to try to give a foundation of what M.P.H is and build that foundation for the rest of the discussion. But before I do that, I want to back up. So I come into this conversation with some of a unique lens. For my entire childhood, my entire life, I grew up in a home with an EMT. Her name is Kathy. And at any hours of the day, she's also director of EMS, still in Ness County. And I got very used to, at any hour of the day, especially the most inopportune times, like right when you're about to sit down for Thanksgiving dinner, the pager goes off. There's no question. It's out the door. It's see you later. I'll be back when I'm back. And we got really used to stopping Christmases midway through present opening to deciding, do we eat or do we wait, and playing those games. And she would do everything she could, and I'm sure this is true for other EMTs if you know them, to show up, no questions asked, address the emergency, help people, and then come home and continue on. But the truth is, a lot of times when she would show up, it wasn't a genuine emergency. It wasn't something that if she didn't respond right then and there and take them as fast as she could to a hospital, that they were in really rough shape. A lot of times it was something that could have been prevented with some services in advance or with the right sort of support. And this is a situation that's not unique to Kathy or to her rural EMS department. We know that a lot of cases, the majority of EMS calls that EMTs, paramedics respond to are not true emergencies. They're things that could have been prevented with the right supports and right services. And they're things that can be managed with connecting them to services, talking through the medication they're taking, reducing a fall hazard, those sorts of things. And so there are people in Kansas and across the country that have begun to ask a question about what types of services can we do, knowing that a lot of these calls aren't genuine emergencies and can be prevented, and running lights and sirens or taking them to the emergency department isn't the best way to care for them. And that fits into this model of mobile integrated healthcare. So here's a definition. I like definitions. This definition comes from the National Association of Mobile Integrated Healthcare Providers. This is such a new area of work model that you can find alternative destinations, but this one's pretty representative and has a few key pieces. It's a coordinated, patient-centered, holistic model. And I think the other really important thing is it's collaborative and interdisciplinary. And oftentimes, the most common form of mobile integrated health, which is the broader concept, is called community paramedicine. And so these are so often talked about together that you may see the acronym MIH-CP. That's this, mobile integrated health / community paramedicine. Community paramedicine looks very similar, and it really focuses on using properly trained EMS professionals, EMTs, paramedics, to provide services often in someone's home, away from a hospital or clinic, and address those social determinants of health and enhance access to care. Ultimately, this is all comes down to these three words, the right care, the right time, and the right place. And oftentimes, the right care is not an emergency save their life CPR. It's things that are connected to social determinants, to things that are non-emergent. The right time is often before the emergency happens in the first place, before they fall and need to call 911. And the right place is in their home. It's not in an emergency department or in a clinic. So what is it? What are some common goals, populations, and services? So one thing to know about MIH and community paramedicine is that the norm is variation. They can look lots of different ways, and we'll hear some different examples Doris will talk about. But these are some common goals, populations, and services. So common goals: prevent hospital readmissions, expand access to care. Can we bring care to people that aren't going to make it to the clinic or to the hospital? Folks that are managing chronic disease, can they be a partner and show up and help them do that chronic disease management? And can it be a alternate destination? So can we, instead of taking them to the emergency department, is there a more appropriate place to take them for the care that they need? Populations can really vary, but these are some common ones. Those that are frequent EMS users, those folks that when the pager goes off and you hear the address, you know exactly who it is and likely what the situation is because you were there last week. Those people that need services and often call 911 and EMS shows up. Another common population are those that are managing chronic disease. They may be discharged and have some needs that can be managed in the home with the right support. Here's a non-exhaustive list of common services that you see in MIH community paramedicine programs. And Doris may talk some more about some of the services and she's seen in some of her programs. You'll notice that not all of them are clinical things. Some of it's referrals, it's connecting people to services in a community. It may be doing things as seemingly small as let's rearrange the layout of your bedroom so you don't fall repeatedly. There's this fall hazard that you keep running into. Can we just prevent that? This is a newer model of care, and the research is really still developing, and limited access to data is one of the reasons that we don't have really great research yet, but there are some areas of promise that we've seen some outcomes, including emergency department utilization reductions in that, and readmissions, and patients seem to be satisfied. Locally in some of our areas, and Doris can talk a lot more about the bottom one, but in Wyatt County, they collected some of their own data and shared with us and saw a 57% reduction in emergency department transportation. And then the Washington County Ambulance District, which is where Justin is from, saw a 52% reduction in Medicare claims. So the next thing I want to share, just to finish up here, is last year, and you'll see some familiar faces in this photo. If you look close enough, you'll see some people that are in this room right now. We had a strategic thinking discussion around mobile integrated health and brought together lots of people in our region, in Region 7, Missouri, Iowa, Nebraska, and Kansas. And it was last August, and we talked about M.P.H and what it would take for it to continue to grow in the region. We had over 100 pages of notes, and when I say we, it was the Kansas Health Institute, my colleagues, and we put those together and processed them and tried to summarize what we heard from everyone. And this is one of the key things that we found. And there's a QR code that will take you to a document that you can access all of this. But the things we heard were best summarized in these three areas: that to move M.P.H forward, and currently the factors that are shaping mobile integrated health are workforce, data, and funding. So I'll just briefly touch on each of these. Workforce. Generally, these programs rely on EMTs and paramedics, and they often have many of the skills they need to provide these services, and they can benefit from additional training beyond their traditional EMS roles. And figuring out how we train these professionals, how we support them, is one of the challenges. And Doris has some good examples from Missouri. Data is a challenge you all are probably familiar with broadly when it comes to providing health services. It's true for EMS as well. Oftentimes their systems aren't built to work with all the partners that they need to work with in these programs. So finding ways to share data, to identify what the most important data to be collecting is one of the challenges. And then the big one that people often want to jump to is funding. And it's the elephant in every room, is how do we fund and support this work? And funding can come from lots of places, but what we heard was a concern and an interest in getting to sustainable reimbursement models from public and private payers. And there's a lot of things that we'll talk about today that go into that. In the center, you'll see two things that are mechanisms for addressing those three areas that we heard. Collaboration, working with partners at clinics, at social service organizations, hospitals, fire departments, and then standardization. So how do we find ways to clarify and standardize those three areas at the state or national level, but do it in a way that still creates space for flexibility, for the program to be tailored to the unique needs of that community? I don't have an easy answer for you, but that's something that came up in our conversation. The last slide I have here is the strategies that we heard. We heard 4 bucket of areas of strategies from this gathering of what it would take to move M.P.H forward. The first is building more collaborations and coalitions to continue these conversations and continue the momentum that we heard, whether that's at the state, regional, or national level. We're lucky in our region to have some really fantastic leaders that I think are playing a big role in this. The second is enhanced data collection and sharing. I already touched on that, but that kept coming up, and finding ways to enhance that. Building the training programs and credentialing pathways so that those professionals that want to do this can be formally endorsed or recognized at the state or national level and provide those services. And then the last piece is that sustainable funding. So that's my foundation. I sorry if I took a little bit of extra time, but hopefully, especially for those that were in that 20% that were new to M.P.H, you feel like you got a decent foundation for the rest of the conversation. There's my headshot and email, but I'll be easy to get a hold of. And you can skip
Thank you,
that.
Wyatt. Yep.
That's just about K-Child. Talk to anyone that wants to learn.
Thank you very much. Endorse, you're up next.
I think I'm up. Well, thank you for having me. And I am definitely no Justin. As those of you that know Justin, he is a very dynamic individual and he's very passionate about M.P.H. And he speaks to a lot of things that I cannot because I'm not a clinician. I don't have that background, but I'm the behind the scenes person of our network. And it's really interesting. If you look at our slide, that is our logo. And then if you click to the next slide, it is actually a piece of each of the partners that formed because we were very committed to this and we wanted to demonstrate collectively that we wanted to move this forward. And so the initial partners were Great Minds Health Center, which is a federally qualified health center, the Washington County Ambulance District, and they are both located in Potosi. Great Minds actually serves 2 counties, and they have now expanded to include the St. Francis County Ambulance District. They're involved with an M.P.H program. Both counties have it operational. Again, there are always these boundary things that come into play. And then community asset builders. And I know FQHCs really well. I have been doing work on resource development and bringing new access points and helping FQHCs with their non-competing continuation applications, that sort of thing. So I just have a lot of relationships. And whenever next slide, please. When we first kind of started this project, I was actually working with the health center on some of their strategic planning and grant applications. And they were talking about this project. And I was like listening, like, okay, what is that exactly? And it was really, it started out a very small project. It was the Missouri Primary Care Association. It was actually a community health worker pilot project that they were funding. And they had asked for, applicants from the FQHCs to see who they would want to fund. And it was to try and take high utilizers of emergency services for Medicaid populations and see if they could reduce those and the cost associated with them and also improve no-show rates by using community health workers. And it was a great concept. I thought it was really cool. It was working really well. I didn't get involved in this until probably 2019. So the focus was improving patient outcomes and clinical metrics specific to diabetes. So it's a very small pilot, 21 people. They were testing it. They were going to grow it over years. And they have continued that program. But COVID hit, and you all know what happened when COVID hit. So when it happened, people stopped seeking they just stopped preventive care. They didn't even go to the emergency room because they were afraid they'd end up staying there or catching COVID. So it really created some concern. If you understand where Washington County is located, it's very rural. They're very sick people. There are high rates of everything there. And the fact that people were not seeking any care was kind of scary because the ambulance district was sitting around not getting any 911 calls. And the hospital was overrun and the health center had staff and they weren't even seeing people other than people that were coming in for vaccinations. And so they just started having a conversation about what do we do? And they realized they had a workforce that could go into the homes. They were very accustomed to going into homes. So they would go into the homes and check on those patients for the health center. And the community health worker was that central role because they were the ones that were making contact with the patients, setting up the visit. Then the community paramedic would go. But while they were there, if they encountered something, which they did, there were some people in really near death with COVID. And so they were able to treat those patients and then telehealth with the providers immediately. And so this little project was going along. This is when I entered the conversation and I'm down and I'm like, this is cool. Nobody I know, and I do a lot of work with community health centers. This is nothing I've ever heard of. I think we should apply for a grant. And there was a grant that just happened. We were talking about it. That's why I was there. I said, this would be perfect for this. It's a heart disease grant. Why don't we see if it works for heart disease like it does for diabetes? So that kind of developed the whole conversation. And we just really realized that people were in crisis and needed care. And that was really kind of the dawn of the project. And so a little more background on the diabetes project because it really set the foundation for everything else that came forward. It was non-compliant folks. The next slide. Yeah, like I said, the CHWs scheduled appointments. And then when the paramedics were out in the home, they don't just go in and just do clinical services. They actually assess the entire environment. They do this anyway. They've done this their entire careers. They go in and try and figure out what are some of the things that can prevent them from calling 911. Because we had some patients, we had a case study with our program, 120 visits in 6 months. I mean, literally 120 transports. They can't afford to keep doing that because if they don't take them to the hospital, those calls, if they don't take them to the hospital, they don't get paid. So it's very costly for EMS. So they were really wanting to see how they could help. So they do home and risk safety assessments. They do a full assessment on things like vitals, EKGs. They can do finger sticks, A1C in the home. They can draw labs. And then they charted a lot of things after we got this going in the health center's EMR so that it was in the patient chart. That was when they just had the one-to-one partnership. After it expanded, we had to modify a little bit. But Washington County, whenever they would go in the home and say it's a diabetes patient, so they have a wound that needs immediate treatment, that would be when they would do a telehealth visit, and they operate under standard protocols. So it's very routine for them. They do this on the emergency side anyway. They know these people. So from there, if you would like to, next slide, what we ended up with for results was a reduction of ED visits by 100%. Every patient enrolled in the program saw improvement. We had 100% patient satisfaction. Everyone's A1C reduced. Compliance increased. They had follow-up care in the home, and there were 0 transports. So EMS didn't have to run calls that were inappropriate. Next slide. After we kind of applied for the first grant, which was the rural health care, it's the HRSAs, and I think I'm sure many of you are familiar with the HRSA funding opportunities. We applied for a rural health care outreach program, and it was their Healthy Rural Hometown, which is the heart disease. We did heart disease, but there were certain diseases that they wanted you to focus on, and we applied for the heart disease project. That just ended in May, actually, and I was sad because it was the foundation of the project. Well, Jim McCrae was kept up to speed on the things that we were doing, and we ended up applying for the primary care challenge and just explaining this new model of care, and actually won the national award for improving primary care with this model. And that's when things just kind of exploded, and there was just a lot of interest in, and Justin's been very busy ever since. And at the same time, there were a lot of other funding opportunities. So we leveraged all those and married them up because we knew it wasn't sustainable. But in our HRHI grant, we said at the end of 3 years or at the end of 4 years, we're going to have a sustainable program. And so when we wrote the grant, I told Justin, what do we need for this to be sustainable? And he said, we need reimbursement. We knew that going in. So we set out from the start how to get those conversations going and get the right partners to the table. The CDC grant was great because it gave us funding for the CHW piece and for training up CHWs and workforce, because you do need them for this model. And then we applied, United Healthcare got wind of it. It was a small amount of money, but they wanted to do a pilot. And so we did a pilot with them. And on that particular pilot, we learned things that didn't work, which was just as important as learning the things that did work. And then we started thinking, okay, you can't do whole person care without addressing mental health and substance use. So that was when on the EMS side, they applied for the FRCAR, which is first responder funding, to actually address mental health and substance use. And those funds really allowed us to really provide Suboxone in the field and to really do treatment and to engage them and then, get them to the right type of care rather than transporting to the emergency room. Our Rural Health Network Development Program was an expansion of the services to another county. So, okay, we knew it worked in Washington County. We knew it worked with the providers that we had engaged. Could you take that, pick it up, take it to a totally different county, not even adjacent, with different providers, different culture, different patients, and it still work? We're in the middle of that project, but yes, it is working, and it is another health center, Missouri Highlands Healthcare, that has a 7-county region in the Boot Hills, so very similar circumstances in terms of lack of access to care. And then we had our Rural Health Network Development Program, which helps support the work that KHI did to bring about the Strategic Directions report, which has really informed a lot of our work moving forward. And the thing that I wanted to touch on that Wyatt mentioned was the workforce piece. We applied for a workforce training grant because very early on we realized it's very challenging, especially on the EMS side. When you pull your paramedics, who are your seasoned paramedics, to be your community paramedics, because you want people skilled, you want people with good experience, comfortable working independently in the home and doing the telehealth visits, and it's a new line of work. So you want seasoned folks. It left a gap on the trucks for the emergency services. And so then you would take the EMTs and get them skilled up to be paramedics. Then you didn't have your EMTs, which was your front line. And so we recognized very early on that we needed to get resources to really provide tuition assistance and engage with training instructors to skill everybody up. And I would like to say we just finished that project. It was a $1.5 million project over 4 years. We skilled up, and it included nurses, RNs, LPNs, community paramedics, and EMTs. And we trained 230 folks, 230 people during that time frame. So, and just for that 6-county region. So it's amazing the amount, and CHWs was the other one. Next slide. So we were very excited about that. This is just briefly the model, and I know it's very difficult for me to do this in 10 minutes. This is like, so just tell me if I'm getting really close. I just have a few more slides. The model is really about the CHW connecting the patients to the CP who provides the care in the home, and then the CP bridges the gap with the provider, really helps with the connection. And even after care, doing a lot of education on what a lot of providers share, especially on hospital discharges. Patients, they don't feel well when they go home, they don't hear half of what they hear, and they need somebody to explain it in lay terms so that they can move forward, much like community health workers. And in Missouri, our model encourages dual certification. So our CPs, many of them are also CHW trained. Because it's helpful for them to help navigate resources. Next slide. This is just a really quick, and it's an old diagram. I need to update it. This is when we just had to throw it together because people didn't understand how it worked. But it has held true for the 5 years that we've been doing it. There are multiple points of entry. I won't go through all of them. The community health workers are kind of the hub, and I know you have a lot of community health worker folks in your industry here. And then they do the connections and address the social determinants of health. And it's really just a visual of what I had talked about in the prior model. Next slide. This is a map of what MIH looked like in Missouri from 2019 to 2022. So in the gray, those were existing MIH programs. They were all urban. There was no such thing as a rural MIH program. They didn't even exist nationally. People just didn't do it in rural areas because they said it was too difficult, and there weren't resources to support it because distance of care was too far. And then the newly established ones in the rural, the first ones to be established were like in 2018 was Washington and St. Francis. Those were early. They kind of got funded very early. And then the pink ones were what we called highly ready. The yellow was strong interest, and the green were needing more information. This was at the end of 2022. I mean, we're not talking very long ago. And then next slide. This is our map today in Missouri. And it shows when the program started up and became active. And that means they either funded it locally, or they got a federal grant or state contract, or they are engaged in a formal network relationship, meaning they have signed an MOU that they are going to move forward and they're seeking resources to do that. This is a slide, the next slide, is kind of a list of our active programs. And I was so excited to hear that there are programs in Kansas. I may not know of all of yours, but I have started a Kansas map as well, because they always ask me in Missouri, well, what are they doing in Kansas? And I'm like, well, I know the 3 Patterson sites because we've helped facilitate some of that education and training. So that list may be updated after today. I'll touch base with you, Alice. The stakeholders continue to grow. This is just a list of who we engaged early on. We had our very first MIH summit 5 years ago. This was our 5th one this year. We knew early on, you can't do grassroots without also concurrently bringing along your state level partners. They have to go hand in hand, because if they don't understand, it won't move forward. And so we did engage a lot of folks, and this list is way longer than this. And I will end on the note that, we have submitted a huge application under the Rural Health Transformation Program, and our Medicaid office is very interested. We have our Primary Care Association behind us. We have our Behavioral Health Council behind us. Our Hospital Association is very supportive. I think they have seen the impact that it can have. And so we're excited, more to come. And this is my contact information.
Thank you, Doris, for sharing that experience with us. And now Amy's going to share what's happening in her community.
I think what I'd say is you're going to hear a lot of commonalities between the three speakers, but I'd also say in each community with each opportunity, the models are going to look different and who you partner with. So don't just shy away. We were approached over 10 years ago, before I started at Health Partnership Clinic, by a collaboration that was already taking place between the Olathe Health, the local hospital, and the Olathe Fire Department. Mm-hmm. Olathe Health was seeing, like most of our hospitals, a lot of transports from the EMS for inappropriate things that could be taken care of in a primary care setting. And so they were trying to figure out, how do we keep these people out of the emergency room when they call 911? At the time, nurse practitioners had to have a collaborative agreement with the provider, and there was some other legality around that. So the hospital could not sponsor a nurse practitioner. And that's when they brought Health Partnership Clinic in. Realizing then at that point, well, it's great. We may do something in the field to keep them out of the emergency room for a bit, but what's going to keep them from now calling the non-emergent or the community paramedic time and time again? So that being the F2HC, the thought was then we would bring them back to the clinic, make the appointments, the follow-up appointments, and establish a medical home. So we operate with the Olathe Fire Department, and we provide a nurse practitioner. All of this was initially funded, and one unit continues to be funded by Olathe Health, which is now KU, part of the KU system. So they are out on the truck. I believe it's now 3 full days, 10-hour days, or 4 10-hour days. But then they're back in the clinic for a half day, seeing or trying to see those patients back within our clinic. One of the really neat things I think about our model is, and this partnership is, it's allowed for some different projects that have allowed that to grow. One of the projects was with Olathe Health. Instead of looking at emergency room revisits, they wanted to look at readmissions, and they called them their VIP people, the individuals who just kept coming back to the hospital and had to be readmitted. So we sat down with key team members, their social work department. How do we come together to prevent, that from happening? And so when a patient was that had been identified as a VIP, they would get a follow-up visit from our mobile unit. If needed, then they would be seen for follow-up labs or anything they needed within the clinic. If they no-showed, the Olathe social workers would then immediately jump right back in, and we would work through that. And we were seeing some really great results. I will tell you, you pointed on data collection. That is a challenge. But we were seeing some great reductions in that, and then COVID hit. And so that project literally went away, but brought on a new project. What did we do with that during COVID? It's like, do we just stay at home? What does this look like? So our team and we are, I failed to say, we're paired with a paramedic and then our nurse practitioner on a unit. They would go to the houses when someone was discharged from the hospital to do hospital follow-ups to make sure they weren't readmitted or going back to the emergency room, because I think we all remember the scenes in the overcrowded emergency rooms. So it's a very great tool to be able to rapidly respond to the needs in the community. I did talk to we ran some data, and I also talked to one of our nurse practitioners and said, what are the main things you feel like you're seeing? And the backup data resonated. So a lot of care management, connecting them. We are the homeless grantee for the federal government here in Johnson County. So connecting them to resources. So go to the Salvation Army Center quite a bit. They see these individuals receiving a lot of fragmented health care. So pulling it all together and then getting them into a medical home. They do a lot of exams and vaccines. I think they are looking forward to the next few weeks as we do a lot of work in schools. A child forgot their nebulizer. Whoops. Instead of going to the hospital, this team goes out. But as we near the exclusion date for schools for physicals or vaccines, they're going out into the schools and providing that service when the school nurses call. And then a lot of chronic disease management, hypertension, high cholesterol, and diabetes. I think the fire department, along with the hospital, really sees it as a way to overcome cost and transportation. That program has really grown. 2 or 3 years ago, the city applied for a secondary grant through the federal government. And about 18 months ago, they added a second unit. And now that unit is fully staffed. One of the hopes had been to even expand further into substance use disorder. A lot of calls are made here in Johnson County for people who have OD'd. And the EMTs go, they provide the Narcan, and basically are able to say, sorry, here's a list. Try, where you can get some help. So the thought was, if we could have a SUD counselor riding along on those calls to have those conversations, to do the warm handoff, whether it was back to Health Partnership Clinic or to another organization, maybe the likelihood of a secondary OD would be negated. Unfortunately, that was to be funded by the city of Olathe, and with all that's going on in our world today, like all of us, they kind of said, we're going to back off some projects. And so that has been put on hold. But that was going to be a partnership between not only the fire department, us, but also the police department. So I think there's a lot of creativity that can go into it to meet needs. Just some really quick numbers. Last year, and again, data is a challenge. So these are what's recorded in our EMR, 415 visits, of which about a quarter of them came back to Health Partnership Clinic and established care. This year, we've seen about 225 visits year to date. So I would encourage you to look at it. Don't think you have to fit into one model and move forward with it. It's a great service to the community. One thing I would, though, add is, for instance, we are partnering with the city. So within the county, we can only stay in the city limits of Olathe. And so oftentimes we will get, can you just go across the street? No, we can't.
Well, thank you, Amy, for sharing that experience. And it's nice to know that those types of things are happening already in Kansas. I know Wyandotte County also has a service as well that they've been working on for a period of time. So I think one of the questions, and I know we had this conversation as we were talking about this, is, a lot of times we run to, how do we sustain this? How do we fund this? How do we make this happen? But I think there's some steps we probably need to do before we get to that point. And so, Wyatt, I'm going to pose to you, what would you say is one of the greatest challenges we need to overcome as we start to have these conversations?
Yeah, I think a couple things. And one is the least policy based, is fundamentally how we view EMTs and paramedics and the role that they can play in providing healthcare. If Justin was here, he would say it better than I do, because he's lived it. But the perception, whether said out loud or in quiet, that EMTs and paramedics are glorified bus drivers can hold back these conversations. So if we don't think that these professionals already have skills to provide healthcare services, if we start from a place of not really seeing them as capable of that, it's really hard to even go down this path. So I think that's one shift, and I do think that shift is happening. But historically, there's some policy things to overcome. Federally, EMS and EMTs, that whole system, generally sits within transportation. That's how they've been viewed for a long time. And a lot of reimbursement models are dependent on transport. So there's some foundational underpinnings that kind of set that we have to overcome, I think, to even open up the conversation. I think once that shift happens, that we see the potential value, and I think that's happening, and we can look to other states to really see it. One of the first things that I think comes up before we can get into sustaining and funding, at least at a statewide level. And as a reminder, these policies are generally state by state. So EMS is a generally state-run policy area. And most of these laws and policies build on the existing EMS policies. We have to wrestle with how do we define and even enable or recognize these professionals to provide these services. So right now, if you do this in Kansas, you're just doing it, and you maybe find ways to fund it internally or with a single agreement. But the state of Kansas, you cannot find community paramedics defined in any policy or statute. There's no endorsement that you can get to be recognized. There's no credentialing pathway. And I do think that the states that we look to that are further along on this, they have those. And there's different approaches, but I think that's one of the first things that states seem to wrestle with is, at a state level, how do we define and recognize these people? And if you're going to define and recognize, that tends to have to involve what are the steps to become a recognized community paramedic? What education, what training, what years of experience? So that often is one of the first steps.
Thank you for sharing that. I think one of the things I heard mentioned a lot, Doris, was just about relationships and building those relationships. And what are some of the things, as you're working on building those relationships and building a program like this, what are some things maybe to avoid as you're going through this process?
We've learned a lot. And I think the key, and it's not so much to avoid, but know going in kind of your audience and what will benefit them. Because M.P.H can have both positive and negative impacts on organizations for different reasons. But what we try to explain to them, it may appear to be negative, but it's not. And a good example is a hospital, and Justin would be very open about this. Their relationship with their critical access hospital in their community was not that great as a result of M.P.H. And the health center and the ambulance district had a great relationship, and they kept trying to engage the hospital. But because you're reducing their ED visits, even though they are not, in their minds, those are visits that are revenue, but they're really not. And you have to get them to look at the data and recognize that even if they're Medicaid, they're probably not paying the cost of that care. Would you not rather we get them into your rural health clinic where you can bill for them and you can run labs for them and you can get their tests and you can improve their outcomes, which will help you secure some incentive dollars or increase opportunities with ACOs. And so that's where we had to do a lot of education with relationships, especially on the hospital side. I think at the local level, there are a lot of things, and it really is very organic, as Amy mentioned. We have some communities that jumped right in to tackle substance use. And then we had others that, I'm going to start with diabetes because I know that's something that we can tackle. But then the partners at the table differ greatly. We have one group that is very jail focused, and they provide MAT services in the jail in Lincoln County. And it's a model that's actually receiving lots of recognition too at the national level because it's having such a huge impact on fatalities, because when people come out, they are staying in treatment for longer periods and they're not going back and using the same doses. So it's definitely prevented some overdoses, but it's just, you have to have relations. You have to be able to get, Justin can't even get a conversation with his jail. You know, the sheriff says, not touching it, just not doing it. But you got to keep having the conversations. And what we have really learned is peer-to-peer works better than anything else. If you've got an FQHC that's doing it, you know, we had great minds talk to Missouri Highlands. Missouri Highlands, Karen came right on board. And then she's had other conversations, and that helps on the FQHC side, same way on the hospital side. And it's the same even with the jails. You get one sheriff that will champion it, they will continue to do it. And even our providers, we're doing a lot around OB, trying to figure out how we can integrate the model with OB at a higher level. And you really have to have the medical directors of both EMS and your healthcare providers buy into this, because they're the ones, at least in Missouri, because we operate on medical direction, they have to be bought in because they're the ones that are going to be providing oversight. So I hope that answers the question.
Thank you. So I mentioned at the beginning that the Patterson Family Foundation has provided some funding to Kansas to start doing some work. And there have been 3 counties in Kansas that have been identified as part of this work. And a lot of this initiative is being driven by the Kansas Emergency Services Association. Did I get it right?
Mm-hmm.
Close. KEMSA is there. Yeah. Okay. So the 3 counties in Kansas happen to be Kingman, Franklin, and Dickinson counties. And most of them have some proximity to a federally qualified health center. So we don't quite know yet what those conversations are like in a couple of those counties, but we do know that some are happening with Dickinson County. So I am going to ask for a microphone to come up. And if Danny will raise her hand, Danny's going to share a little bit about what she's been experiencing with this work in their community. Thanks, Danny.
Thank you. We've had conversations with Dickinson County EMS, and it's really just initial conversations at this point. We have a very, very small medical-only clinic in Chapman with a lot of Medicare age patients, and those conversations have mostly been between that physician and Dickinson County EMS, talking about what would be helpful, what the provider sees as a need for his patients, and how documentation would work, how billing would work, the EMS or the connection of the systems, documentation in the record. But a lot of interest from Dr. Freeze, our provider in Chapman. He thinks this would be value added for the patients that he serves. And I think they're building momentum. They just pushed us their policy and procedure manual that they've developed. They've been planning for some time and then had a little bit of a staff transition due to an emergency. So it got put on pause for a little bit, but we're excited about where it could go. And from our perspective, it would be really helpful to have that available in Gary County because that's the vast majority of our work. But we hope to learn a lot from Dickinson County in the partnership in order to see what could be possible maybe in our neck of the woods further east.
Great. Thank you. We're excited that you're part of that work. I think we're going to open it up now for questions from you all. And so that if folks have questions they want to ask of this group, please do so. We might ask questions of you. Anybody working with Franklin County? You might. Yeah. Kingman County. Anybody had conversations tied to Kingman County at this point?
And one thing I'll add, it looks like he stepped out, but David Jordan in Kansas at the United Methodist Health Ministry Fund has been very involved in this work as well and has lots of insight. So if you run into David, you can ask him about this as well, and he'd be happy to talk about it. One other thing that I would add, and I think we do have this opportunity in Kansas. So going back for that, what are some of the first steps? We have some new pilots. We do have some programs that are already running. And I think really learning from all those and being really thoughtful and intentional to say, how did this work? How could we use this data that we did collect to inform what the state does as a whole. We do have a really great opportunity. And I think across the state, encouraging ourselves to reach out to those states that have been doing this for longer. And there are different approaches. If you look to Minnesota, they're one of the first states that went down this path of enabling MIH. And they have Medicaid reimbursement for MIH services. But with that, they have some very specific what services can be provided. It's really detailed. Missouri is much more open and much more deferential to the Medicaid oversight or medical oversight. There are different approaches out there. I think Kansas is at a point where there are really good leaders in the state wanting to have these conversations. I hope we all just really be thoughtful and intentional about making the most of the pilots and the working opportunities.
Definitely. And it's also, I think, that opportunity for that community collaboration, because it doesn't just have to be one entity participating or two entities participating in the initiative. It could be multiple organizations that are working together.
That's what I was going to add. And that's why we actually have ours. We do MIH CP because some are CP programs where it is very much, they're doing mobile integrated healthcare, but it's just one entity like a fire department or an EMS agency. They don't even have a healthcare partner. They're doing it for totally different reasons because they have to figure out ways to reduce costs. And they figure it's better to invest on prevention than to keep running trucks and not having anything change. But I also think what we learned a lot of, because it is very organic, and Washington County was a great example. They started out with just that one partnership, that relationship, thinking that's what it was going to be forever, was the partnership between the health center and the ambulance district. But then everybody started saying, well, how can we be involved? How can you provide services for our patients, like our CCBHCs? And private providers started saying, I have a patient that I want to get enrolled. And so that's where the data issue becomes a nightmare, because when you can chart in when the EMS agency is out there doing the work and they can chart in an EMR, that's great. But if they've got 10 different EMRs, that's not realistic. And so a lot of the movement in Missouri has been to one type of platform. I wouldn't call it an EMR. We're calling it an MIH platform that eventually it collects data very similar to the data that your EMRs collect. And so we're hoping with an HIE or some type of hub in the future to be able to connect so that EMS could actually be part of an HIE, and their data, their clinical data from MIH could be pushed, and it could be bidirectional. So those are the kinds of things that we see as real transformative. And it has to happen in order for care to be delivered to folks in the environment we're in today. And I just see the EMS workforce as an under-leveraged healthcare workforce. And this is an opportunity. They have the skills. I've seen the type of training that they go through, and it's just incredible that they don't get paid for those services. So
one more opportunity for questions. All right. Well, please join me in thanking our panel for this discussion. It will continue